Hi everyone, very warm greetings. I am Dr. Saurabh Dikshit. I am a practicing surgeon from Dwarka, New Delhi. So today I am going to discuss a very interesting and a very important topic for my patients, for all my students who are doing residency in surgery, or for all my students who are actually preparing for NEET and all other examinations like AIMS, PGI, JIPLA. So the topic that I will be discussing today is a very interesting topic. It's a very short and very interesting, and that is fistula in ano. Fistula in ano. This is a very common problem. This is a day-to-day problem, and majority of the patients keep on suffering, suffering, suffering. Why? Because they don't know what the scenario is. They keep on visiting wrong consultants and getting the wrong treatment done. So let me today highlight what is it, how to approach it, and what should be the ideal treatment so that yes, we can get rid of this problem. So if you talk about the concept of fistula in ano, what is it? Do you know? Let us see the basic anatomy of anus and anal canal. Do you know this is known as anal verge, and here this is external sphincter. Do you know external sphincter? Yes, this is external sphincter, which is actually continuation of what? Levator ani. Levator ani. And here we have a lot of glands. We have a lot of glands. Yes. This is a cryptoglandular tissue. These are actually glands. Glands. So glands have a function of what? Yes, secreting out some secretions. Do you know we have something which is known as internal sphincter also? Internal sphincter. This is where the internal sphincter is. This is where the internal sphincter is. And then we have a line, yes, which is known as dentate line. Dentate line. Actually, if you talk about the importance of dentate line, the anatomical anal canal starts from the dentate line. Above that, it's a anatomical rectum, but not as far as surgical rectum and surgical anal canal is concerned. Do you know these cryptoglandular tissues? They always drain themselves in these crypts of Morgagni. Do you know there are crypts? Crypts are depressions. So there are crypts which are known as crypts of Morgagni. So crypts of Morgagni. Crypts of Morgagni. So these are small pits which are present in the what? Yes, at the level of dentate line. So whenever there is infection and suppuration of this tissue, yes, there is collection. This is what is known as perineal abscess. And what happens, patient don't get treated for perineal abscess, rather they continue it for a long time. Do you know the pus or the purulent tissue will always find its way out, and ultimately what happens, this is going to necrose of the nearby tissues and create its own way out and drain into the skin. And by default, you know, one opening is at the level of what? Crypts of Morgagni. So if you see, there is a cave which is having one opening on the skin, one opening in the anal canal. Generally or mostly it is at the level of dentate line, and this is what is known as fistula. Since it is in anus, it's a fistula in ano. So abscess is acute. Abscess is acute, and yes, it becomes, if it becomes chronic, if you leave it for a long time, this will convert itself into fistula in ano. Now, for my patients, for my students, try to understand what are the types of fistula in ano. What are the types or classification types of fistula in ano? For this, we have a very famous classification which is known as Parkes classification. If you talk about Parkes classification, what is special in this? Now, instead of writing what fistula it is, I'll help you recreate yourself what fistula it is. So next time when you see MRI, when you see a patient, you should be able to answer ki this is what type of fistula. The rule is, what is the rule? The rule is always name a fistula, name a fistula by location, by location of its tract with respect to external sphincter, with respect to external sphincter. Students, if you know this, you know everything. There are many people who find a lot of challenge in deciding what type of fistula it is. The rule is always look at the fistula from the level of what? External sphincter. From the level of external sphincter. Now let us see this thing. Let us see this thing. The first fistula that we are going to say is, this is the anal canal. This is the dentate line. This is the external sphincter. This is the external sphincter. You know, external sphincter is a continuation of what? Levator ani. And imagine this is the tract. This is the tract. This is the tract. Yeah. Now, I hope you know this is internal sphincter. Here you have what? Internal sphincter. Now, the first job is always look at the fistula with respect to what? Your position with respect to external sphincter. So you are standing at external sphincter. Where do you see the tract? You see the tract in between the two sphincters. Do you know this is a groove? This is a groove which is known as Inter-Sphincteric groove. This is a groove which is known as Inter-Sphincteric groove. So this is known as, this variety will be known as, yes, Inter-Sphincteric. So the A that I have labeled is Inter-Sphincteric. Inter-Sphincteric. And do you know Inter-Sphincteric Fistula nano is the most common overall, most common, approximately 40% of fistulas are Inter-Sphincteric. Next is, now let me create a second scenario. We have a fistulous tract like this, which is opening onto the skin like this. Now what do? Again the logic is stand and see the tract with respect to. If you see the tract in this case, the tract is actually traversing the person. Traversing the tract. Tract is actually traversing the external sphincter. So this will be what type? Yes, this will be very good. Yes, this is a transsphincteric. Transsphincteric fistula nano. This is a transsphincteric. You know, this is the second most common, and approximately 25% to 30% might present to you with this kind of thing. The next is, so these are two types. There are few others also. Let us see them. This is anal verge, this is dentate line, this is external sphincter. Yes, here you have internal sphincter. Let us see them. Okay, let us see them. We have a fistula with internal opening at dentate line. The external opening is like this. Yes, and it is opening onto what? Yes, the skin. Now what is this? Try to understand. You have to stand where? You have to stand, yes, at the level of, external sphincter, and then see. So you place yourself here, and now what do you see? You see that the tract is superior to yourself. Yes, and that is why this variety, this is C, this is known as suprasphincteric. This is known as suprasphincteric fistula nano. Suprasphincteric. And this is what is 15%, 10 to 15% of the fistulas are suprasphincteric. Now let us see. There is a fistula with external opening here and internal opening at the level of rectum. Can you see? The internal opening is at the level of rectum. Imagine this. The external opening is here and the internal opening is at the level of rectum. This is the scenario. Now you are standing with respect to what? External sphincter. Now you cannot see. Why? Because this is quite away from the reach of sphincters, and this variety where the internal opening is at the level of rectum, not at the level of what? Dentate line. It is not at the level of dentate line, it is at the level of rectum. This is known as extrasphincteric. 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 This is the rarest form. This is the rarest form of sphincter. Now, whatever be the type, the management is planned very meticulously. Let us see. What is the management? The first line or the investigation of choice here is a MRI. If you don't do MRI, you will not be able to differentiate what type of fistula it is. Sometimes the fistulas may be complex also. Sometimes the fistulas may be complex or a horseshoe fistula. What is a horseshoe fistula? It's an anterior fistula which is actually opening in the what posterior half. Okay, MRI is the investigation, or you can say better to write as MR fistulogram. MR fistulogram. MR fistulogram. When it talks about the treatment, there are many options. Yes, one is lay open fistulotomy. Lay open fistulotomy. What is lay open fistulotomy? What is lay open fistulotomy? Try to understand this thing. If you talk about lay open fistulotomy, you will just open up this tract. You will just open up this tract. This is lay opening, and then you will do what? Curettage. Then you will do the curettage of this thing. So basically, this is a debridement of the what? Yes, unhealthy tissue. Then second is fistulectomy. Fistulectomy. If you talk about fistulectomy, what is fistulectomy? Let us see what is fistulectomy. Yes, it is excision of tract. It is excision of tract. What is a common problem in this fistulectomy and fistulotomy? Yes, there is a high risk of incontinence. High risk of incontinence. Incontinence. Do you know why incontinence happens? Because of damage to external sphincter. Internal sphincter will not cause fecal incontinence. It is the external sphincter which is actually very, very, very important. So now what I am specialized in, we do at our center a surgery which is known as lift. What is lift? Yes, ligation of inter-sphincteric fistula tract. Ligation of inter-sphincteric fistula tract. Now, what is this approach all about? Try to understand. This is the what? Internal sphincter complex. Yes, and this is the anus. And then you have external sphincter here. You have external sphincter here. Yes, this is. Now, let me show you a tract. This is the tract. Imagine this to be a tract. This is a tract. So what is done in this case? You first make incision in the inter-sphincteric plane. You make incision in the inter-sphincteric plane. Once you have made incision in the inter-sphincteric plane, now what you will do? You will ligate. You will ligate one end here. You will ligate one end here. So you have actually ligated the fistula at two ends, and now you will cut through the middle segment. Can you see you have discontinued the fistula also? Yes, there is an option that you can excise the external tract or curettage. This is what is known as lift. Do you know lift is the best procedure nowadays? It's the best procedure, and why it is the best? Because it is associated with minimum risk of damage to external sphincter. So minimum risk of external sphincter injury is seen here. This is what is beauty of this procedure. Next, the last is, yes, you can go for there is one surgery which is known as WAFT. Yes, video assisted ablation of fistulous tract. So here there is a special probe which is inserted into the fistula to see the tract and to ablate it. Do you know over the time the American Colorectal Association has said that there is no added advantage of this, rather this is a cumbersome time taking procedure and there is no extra advantage of this, rather the incidence of sphincter injury might increase. However, there are people who consider it to be still a gold standard for some cases, but as far as our centers are concerned, we don't perform this because we follow the American Colorectal principles now, Surgery Association principles. Then there is something which is known as setons. Setons. Do you know what is setons? These setons are for elderly, yes, inoperable patients. Elderly, inoperable, or or it is for extra sphincteric fistula in anum. Extra sphincteric fistula in anum. Let me explain you to the principle of setons. Setons are of two types. They are draining seton, or it could be a cutting seton. Draining seton or cutting seton. What do you mean by draining seton? Draining seton is a tube which is placed inside and which will facilitate drainage and evacuation of what pus. There will be no pus accumulating in the what fistulous tract, and along with that you will give an antibiotic coverage that will allow the fistula to heal. This is for elderly, you can say inoperable patients. What is the concept of cutting setons? Now try to imagine, suppose this is a case of extra-sphincteric fistula. Extra-sphincteric fistula. This is sphincter complex, and can you see this is too deep inside? So you tie a suture around this and you tighten it progressively. Suppose this is day 0. After 4 weeks, yes, what will happen when you have tightened the suture? This suture will bring the tract a bit down. A tract will be a bit down. Again you will tighten it. Yes, again you will keep on tightening it until and unless this tract comes close to the skin, and then you can just cut and operate it. This is what is the principle of cutting seton. Imagine a case that, yes, in our childhood days we used to do this prank with our friends. Someone who was flying a kite, and we used to, yes, attach a stone to a thread, and then used to, yes, and throw it towards the string of the string of the kite, and then we used to pull it down. This is the very same principle. You're bringing the trap towards yourself. This is the principle of cutting seton. You put a suture and you tighten it progressively over the time. This is what is. I'll show you two cases. One a case of lift, and one a case of, you can say, lay open fistulotomy. So I'll show you this case. Try to see this. Can you see? I have a metallic probe which where I'm opening. I'm showing you the tract. This is the tract. This is the tract. I'll show you this. I'll show you this thing. This is the external opening. This is the external opening, and this is the internal opening. This is the internal opening, and this is the fistula that is present here. This is the fistula. Since this was a very superficial fistula and a small fistula, I opted to go for lay open fistulotomy. So what I will do now, I'll give you the principle of lay open fistulotomy also. I'll just show you the principle of lay open fistulotomy. Yes. Okay. What is the principle of lay open fistulotomy? I'll show you. In this case, what you will do, you will just open up this fistula and then just curate it. I'll show this to you how we do this. So let us see this. And with the help of a diathermy, we'll just open up this. Can you see I've just opened up? Yes, I've just opened up this, and now I will be doing some curettage part of this. So this is classical of lay open fistulotomy. Just see, I'll remove the necrotic tissue. The cameraman has not taken it that perfectly, but still, can you see? Yes, I'm curetaging. Yes, I'm curetaging it. Yes, I'm curetaging, and beautifully I have debrided all the dead tissue, Yes, beautiful. And next, I'll show you the concept of lift also. I'll show you the concept of lift in one of a patient. Now, can you see this thing? You will get hold of the fistulous tract. Once you have ligated it, you will just cut it. Cut it in between, and the things are done. You make the incision in the inter-sphincteric groove. This is the inter-sphincteric groove that I'm talking about. Yes, and then, yes, you will lift up the fistula. You ligate the tract. You have to dissect it off. You have to ligate the tract, and you will just cut it. This is This is very simple. This is very simple. So I hope you liked that video. It was a bit informative for all of you. So if you really liked it, yes, subscribe to my YouTube channel and I'll keep on updating you with all the other such videos. Till then, bye bye.